I think now we will invite all the presenters up here. You can see these chairs are kind of symbolizing what EFSA wants to be transparent. So, and yes, now we have 30 minutes for discussions, further questions. And I suggest that if we try to organize it a little from the beginning, so if I can invite questions to the first three speakers this morning in relation to risk ranking, disease burden. So the floor is open.
Thank you. Ákos Zsuzsák from Hungary. I would like to ask about a very blurry area between risk assessment and risk management. We are trying to incorporate in our decision-making the health-adjusted life year concepts into the different intervention techniques, how they affect the outcome of the health outcomes. And my question would be if WHO or EFSA or ECDC is willing to work in the future on different guidelines and methodologies that which method could be used in that area between risk assessment and risk management when we are trying to translate the assessment results into which intervention technique should be used during risk management. Because for us it's a great question, since it's the scientific methodologies and the tools used and the expertise needed is very similar to the assessors. And in a small country like Hungary, more or less the same people will do this job and the classical assessment job. So are you planning to work on that area? Thank you.
Okay, perhaps if I would take a few more questions and then go back. There's one here.
Yes, okay. I'm Lisbeth Jacksons, Ghent University. I have a question related to the presentation of the first two speakers, related then with the presentation of Professor Koopmans on the viruses. So what we saw in the disease of burden and the risk ranking, these are well-established hazards. Yes, but how to include emerging hazards if you look then for the viruses, for instance? So how could this link be made in that work, both risk ranking and burden of disease? Thank you.
Okay, one more, and then the panel, yeah. Here.
Wolfgang Kneifel, BOKU, Vienna. We have heard a lot about the bad bugs this morning. What about the good bugs and their risk? Do you think that the so-called QPS approach is sufficient? Are there any modifications to be seen in the future? And what is your opinion or the opinion of the biohazard panel with experience of the application of this QPS approach?
Okay, I think these were three slightly different questions, but I would now open the floor. I don't know who will take the first answer in relation to perhaps from this about disease burden. So I will give you the mic here.
Thank you. I think this is a very relevant question because the prioritization process is only the beginning of decision making. In the European system, the next steps are the responsibility of the Commission. We have debated several times, I think, in the BioS panel, for example, should we do those estimates as well? And basically, the Commission has the responsibility to think about interventions and to evaluate them. Partly, of course, risk assessment models will help to establish what I tend to call the effectiveness of intervention methods. What can you do about it, and how many cases or what burden can be prevented by particular interventions, which is a part of the whole debate. The next step is the efficiency. How much money do you have to invest to make these interventions happen? This is, for example, the Commission has outsourced from their own responsibility for salmonellosis and for campylobacteriosis, they have outsourced economic analysis where not only the benefits of the intervention but also the costs are involved. And I've, in my work in the Netherlands, done similar studies for campylobacteriosis where we looked at the cost utility of many different interventions to control Campylobacter on broiler meat. So the scientific approaches are available. But they have to be organized carefully within the European context. A third part that is also relevant is what I tend to call equity. Even if you have a cost-effective intervention, the benefits and the costs may be divided very differently across the society. In many cases, industry will have to pay for the interventions, and the benefits are for society at large. So there also needs to be a consideration of how can industry recover the costs, how can you provide a level playing field, and again, that's a risk management responsibility. So I think in some of these domains, EFSA plays a role. For all of these domains, scientific methods are available, but they need a much closer dialogue between the risk managers and the risk assessors. And I encourage your point. A dialogue on those aspects needs to occur, and it needs to be much more structured in the European context.
Okay, Alessandro, do you want to comment also?
I just wanted to add something from ECDC's side. As Ari was saying, ECDC and EFSA as well, to a certain extent, have the remit to do the risk assessment. The risk management is in the hands of the Commission. But we are trying to implement a bit more on the side of giving options for inside, within the risk assessment, also provide options in terms of analyzing what are the different interventions that are possible. And maybe in the future we might manage to go all the way down to do some sort of cost effectiveness, or at least cost of illness studies, in order to better inform the Commission during their risk management decisions. We already do some sort of in these rapid risk assessments that ECDC does. There is some, let's say, we start to touch upon the intervention side as well, but it's a general overview, of course, of what is available and what would be the consequences of all those.
Okay, and I think also Steve has a comment on that question.
Thank you. I think that question about uptake of dailies in particular by regulators is something that we all need to be interested in, and because in the end it's regulators that really provide the momentum for this new science. And I think just casting back on history, when we think of where this all started in the mid-1990s with the SPS agreement, for once in regulators' lives, policy and principles were ahead of the science, in that the whole world moved to a risk-based approach to trade, and that was so that there could be an equal platform in terms of the WTO agreement. And at that time, principles and practice were ahead of the regulatory system, and science was behind. We didn't have the science of micro risk assessment, but I think 20 years on, we now do have amazing science around risk assessment, and it's now the regulators that are way behind in taking that up. And if you just look across our regulatory systems in terms of the metrics we use for measuring risk and judging equivalence, if you look at the criteria we use for determining whether food is safe or not, and even elaboration of levels of protection, the science now is way ahead. And I think there were some good examples today from that work where we need to actually promote these new ideas around risk ranking, use of new metrics like dailies, in terms of judging the equivalence of food and trade. And I think Costas put up a very interesting slide in those terms where he said foods, we can either have a single hazard and many foods, we can have many foods with a single hazard, or we can have many hazards and many foods. That's the reality of trade and a lot of commodities crossing borders, and it's very difficult for us to actually judge equivalence in that frame. And I think with tools like dailies and ranking systems, where there's a threshold of probability that takes care of uncertainty and takes care of some of the difference in data sets, I think there's a great opportunity there. to actually promote some of this new science in that trade arena.
Thank you very much, Kostas.
Yes. Okay. Yeah. Again, to this question, which I think it's really important. So first of all, the rule, at least in the European Union, is that the risk assessment is completely separated, or at least distinguished by the risk management. So us, as risk assessors, we provide all the information, for example, about the effectiveness and the importance analysis of the different interventions, and then the risk management make the decision. However, in many cases, as risk assessor, we see that, okay, we provide the scientific information, but the decision by the risk management is completely different than what the information, the risk assessment says. So this is where the risk communication comes, and it's really important that transparency about the decisions, both in the side of risk assessment and risk management, should be clear, and should be high transparency in order for the people to understand why a decision is made. So I think that risk communication is also the connection between risk assessment and risk management. It's really important to be transparent.
Okay, thank you. I really agree on these last comments, and we have been focusing so much on transparency in the risk assessment, communicating and assessing uncertainties, and what happens then in the risk management area. But also, of course, we need to take into account that they have very many other things to take into account, values, politics, and so on. So. But still, I think for all more transparency there would also be important. Marian, would you like to comment on the second questions, how to take into account in these things the emerging pathogens, viruses, and so on?
Yeah, well, I think the question was addressed to the people that are in the risk assessment science, which I'm not. But I do think something is needed there. If you look so I'm in the emerging infectious disease field, we've seen really a shift in approaches from the laboratory science, from the epidemiology, from thinking about risk-based hotspot surveillance, and there's a session parallel here addressing that. Is there something like that also in the risk assessment world? Because I do think this long trajectory, which is very elegant, is not going to help us with all of these emerging infections. So I would defer the question to some of the people here.
Because I think I had the pleasure to work with the area on actually some tools to deal with emerging risks. So perhaps you could give some information and comment on that area.
Yeah, I'll be happy to do that, but I'd actually like to refer more now to a project that's funded by ECDC, led by Martijn Bouwknecht from our AVM, which I'm also still involved in some way, where the question indeed was, now we have these DALIs for all the established pathogens, what to do about all the emerging pathogens, and what is trying to be done there, also learning from the lessons that Kostas has sketched out, that very simple decision models are not very informative and actually can be pretty wrong. What is tried there, and there's no guarantee for success, but at least it's tried there, is to, on the one hand, develop some idea of how big an epidemic might be if it would go on uncontrolled, by using basic principles of infectious disease dynamic modeling, and trying to create relatively simple models using relatively simple inputs to get an idea of how bad might the situation become, and then in interaction with people who know about those pathogens, who know about those diseases, so try to create a dialogue with the disease experts to try and get credible estimates for at least ranges of the parameters and put them in a simplified framework. On the other hand, the impact, often even if disease is emerging, there is something known about the impact on the individual case. So something like a DALI per person may be estimated relatively quickly. Mortality is often a big component. Something is known about case fatality ratios, about susceptible groups and the proportion of susceptibles in the population. So you can also quite rapidly within an emerging disease outbreak start to estimate the impact on the individual, the DALI per case. And if you combine those two elements, you already have part of the, say, the priority setting information available. I think the big concern for many decision makers is more the social scientific aspects. How much of a scare will this particular pathogen cause? And that's something that is still the project is struggling with. How we do that? Because we also know that the social appreciation it's much more fluent. It's much more time dependent. There's not, say, a particular pathogen does not always cause the same amount of scare. It varies with media attention. It varies with other factors. So getting that into the decision framework is I think more challenging and needs a lot more dialogue with social scientists. So maybe I should give the microphone now to my neighbor, and maybe he can also comment something about that.
I unfortunately have to recline because I wasn't able to properly follow your line of reasoning in terms of the medical issues. Sorry.
Yes, so just to complete the project that you were mentioning that we are working on together also with Martijn at ECDC, some weeks ago we tested the methodology with, we also work on substances of human origin. So what is the risk of transmitting diseases through transfusions or organ or cells and tissue transplantation. And we had an expert panel coming on to Stockholm. They were all experts in bacterial diseases. This time we only tested them for bacterial diseases, not viruses, but it's the first step because the Commission asked us to understand what was the risk for bacterial disease infections. And we had them all in the room, and we adapted together with Martijn the criteria because there's quite a lot of criteria that is tested within the emerging pathogen project, but we restricted that to 4 criteria: the risk of transmission, the severity, which weighted a bit more than the other 2 criteria, which were let's say, the progress in the next years. So if it would have been, there were chances that the bacteria might increase, and the AMR part. And it took us a day and a half to agree on the criteria, the definitions, and the levels. So, for example, the severity, we decided to use the DALI per person. And I showed them what was the DALI per person in BICO 2015 as a benchmark. And all the other levels. And also on the weighting, if the first 2 were to be weighted a bit more. And then we went through a series of 16 bacteria that were relevant for these substances of human origin, and came out after a day and a half with a very nice criteria both for transfusions, for cells and tissues, and for transplantation, and also a general criteria that would encompass all 3. So it was a very interesting validation process that we went through. But of course, ranking the emerging pathogen is bigger, and as Ari was saying, encompasses many other criteria, like what we call like the social distress. But we are right now in the process of weighting all those criteria, and the way we're doing it is very interesting as well. We have examples, and where the different criteria have different levels, and we're asking European experts, which for us means focal points within the member states, and we will also ask during ESCAIDE, which is a big ECDC conference in Stockholm that will happen in a month and a half, to go through them and rank what they think would be the disease with the highest impact, and the results of all that will give us an idea of what and how the different criteria should be weighted. And then this will be a toolbox that will be available hopefully next year.
Okay, thank you very much. I think now we should also open the floor for the second part of the session. So now questions could be taken for all the speakers. So, yes? Oh, sorry. Sorry, there was a question in relation to the good box and the QPS. Actually, I don't know if there are any of you in the panel who will comment on that. Well, my personal comment is that, yes, well, when we talk about risk assessment here today in this setting, we have been focusing on the as you said, the bad box, but of course we should also deal with and take into account innovation and food technology, and we know that there's a lot of bacteria which are very good and useful, either because they give good taste or have other beneficial effects, and the way we deal with some of these are through the QPS concept, and I don't know if any of, personally I'm not completely familiar with the exact status. I know we have been testing or evaluating several bacteria in relation to the QPS status. I'm looking at Ernesto. Do you have would like to comment on this? You will have the mic here.
Perhaps it's not the place to explain fully what QPS is, but QPS is just an internal tool in EFSA. It's not something that has been thought to claim QPS status outside the EFSA remit. So it's something that we do to simplify the safety assessment of some microorganisms that are sent as applications to other panels, such as the FIDAC panel or the GMO panel. So it's really a tool, and it's the responsibility of the biohazard panel to maintain this list, this positive list of QPS microorganisms. So it's, yeah, I think there's a lot of misconception out there about what QPS is, despite many times that we have tried to explain what this is about. So it's really, for example, not about looking at the safety of microorganisms added intentionally to foods for human consumption. This is not in the scope of QPS. So it has a very concrete remit. Okay, thanks.
Okay, then I leave the floor open to again all the speakers, to also in the last part in relation to the new typing systems, in relation to how to manage crisis. So questions, comments? Yes, there's one down there.
Thank you. I have a question probably directed towards Professor Koopmans, but maybe someone from the panel might pick it up as well. Is this word foodborne? Professor Koopmans put up some data from a colleague showing the proportion of norovirus cases which are foodborne. I'm just wondering, maybe the panel would like to comment on maybe breaking that word down a bit. So looking at norovirus in particular, is there a utility in considering the different epidemiological pathways of a food handler contaminating the food with norovirus at the very end of the food chain compared to a food chain with inherent pre-harvest risk characteristics like bivalve mollusks? And then also maybe considering the secondary spread. So norovirus is known for its secondary spread. Should we regard those secondary cases as foodborne, given that they owe their existence to an initial foodborne case? So just the word foodborne, what does it mean?
I think that's a potentially long discussion. In the work that I quoted, what is done is look at the virus diversity as information on what the sources of introduction or of the human exposure have been. So that encompasses then also potential secondary transmissions. So that by default, I think that approach does include some of the person-to-person transmission that follows the initial foodborne introduction event. And I think I want to ask Ari to see how FERC has defined the foodborne criteria. In my mind, looking at the virus problem, yes, there is a clear distinction between the food handler borne versus the other, because the food handler, because of the types of interventions that are available, but also because of the hard to define, but the associated risks that are associated with the more diffuse outbreaks. So the environmental contamination-related outbreaks, that's where we see these mixtures of exposures with human and animal viruses mixed, and I think that is something that really requires a different type of approach in terms of intervention, but it's also one that raises the flag for this is something we should be preventing with me as a virologist more than the food handler outbreaks that are about hygiene. So for me, that's a clear distinction, and my push is more about the second category. So the source contamination, where you have you have contamination events with food from all over the world that really shifts pathogens around, that we don't really know what the effects are of these combined exposures. Now, for how much you attribute to food, I guess that's really a question how the FERC has done that.
Yeah, as I showed in my slide, we have defined food as really contamination at the moment of consumption. Of course, the data that our experts have based their judgments on do not always provide that level of detail. So then the question becomes, how have the experts interpreted the evidence that they had available from different studies? They had information from case control studies, from molecular typing, and we asked them to base a judgment on the proportion that was foodborne based on that. And of course, we don't know exactly what went through their head when they did it. So I think at some point this becomes a difficult debate how to exactly pinpoint this down. A debate that we have also had is that the point of consumption may not be the most informative for decision making. For example, we can think about contaminated vegetables in a household. It may actually be the water that the vegetables were washed in the kitchen that has contaminated those vegetables. So managing the problem would probably be more effective when you manage the water quality than when you manage the salad or the other source. So for some of the hazards, we also try to go one step further and ask the expert the question, now what is the most likely source of contamination of the food that was actually ingested by the consumers at the moment they ate that food? And we're still analyzing that work. A manuscript will probably be available for a limited number of hazards somewhere during next year. So we're trying to address that question as well, but again, in the limited amount of data that is available, it is difficult to exactly pinpoint where it is. So your question, I think, is very relevant, is well taken. We often lack the data to answer that question with precision. There's many different source attribution methodologies, and they all tell you something different. If you go to molecular typing, it tells you something about the reservoirs. It doesn't necessarily tell you something about how exactly did the pathogen travel from that reservoir to the humans who ultimately got infected. When you do case control studies, it tells you something about what the direct vehicle of transmission, but it may not tell you where exactly the contamination came from. And I think the holy grail in the attribution world is to have an analytical framework that combines all of that information, and we don't have it. And I don't think we really have an idea, even in a theoretical perspective, how it could work. And if we had it, data would be very difficult. So we'll always have a degree of uncertainty around the attribution estimates.
Okay, thank you very much. I'm sorry, I've been told that we should finish on time here, 1 o'clock. So I hope that everybody who have, yes, no, I think actually we need to stop now. I can invite you to go directly and talk to the speakers. So now, first of all, I would like to thank all of the speakers and the audience for a nice morning here, and then I will give the word to Steve for a final concluding remark.
Thank you. Well, it's been a great session this morning and quite diverse, and we have covered a lot of territory in terms of new science. And the challenge to us all is, how do we actually turn that into practical use and uptake by risk managers at both the national and the international level? And that is definitely a challenge to us all. And we certainly have seen some of those challenges well illustrated this morning when it comes to ranking systems and uncertainties, about our very limited knowledge on attribution due to foodborne viruses. What metrics do we choose when we're communicating risks to managers, industry, and the public, and et cetera, et cetera. But there are some great opportunities in all this, and I think when we strip the wood from the trees, that we are taking great steps forward in terms of practical application of MRA. And I think we all subscribe to the view that our goal is about continuous improvement in food safety, and there's absolutely no doubt that microbiological risk assessment is the key tool to provide those insights that will allow us to continuously improve the situation for consumers. So thank you very much for attending. It's been a great session, and we'll see you all again sometime, I'm sure.